at the moment. A very short talk. I am not going to depth of it. And then we have videos on cannulations of ECMO, followed by videos on initiation of ECMO. When we initiate ECMO, what are the changes that takes place? Because whatever sir has taught, beautifully narrated, but then if you see the visual impressions, that will definitely be better remembered. So ECMO cannulations. So first of all, you have to think about select cannula, size of the cannula, site of the cannulations, cannulation techniques, what are the complications during cannulations, and position of cannula. As I told you, cannulation is the airway of ECMO, so that's most important. If you have proper cannulation, then you have a better flow, and if the flow is better, you definitely have a much better outcome. Accurate and secure ablation is adequately sized cannula is prerequisite of successful ECMO. Type of cannula, single limit or double limit, spiral reinforced or simple cannula. You have a smart cannula or Avalon cannula, different types of cannulas available, you have to select that. Anyway, smart and Avalon cannulas are not available here. And you have to select the size of the cannula. This is the cannulas, the double limit cannula, the arterial and venous cannulas, 12 French and 14 French. The double limit cannula, the set is the set with the cannulas. These are the spinal coated cannulas, so that there is no peaking in that. And if you see the tip is not radio opaque, you don't see actually the tip. Wherever you see the cannulas, at least the actual cannula position is 1 inch above that, because the cannula is not seen, or the tip of the cannula is not seen. There is the side wall cannulas, biomedicals. So when you select a cannula, you have to keep in mind side holes, the number of the sides of the cannulas, the configuration, whether you to go for a VA ECMO or VV ECMO. And as I told you, the most important is the number, the number which is there. So every cannula, every company has cannula, they have a flow chart. So they always give that with this particular number of cannula, size of cannula, this is the maximum flow that you can achieve without any much resistance. Okay, that is what the M number is. So you have a cannula in French, okay, and in millimeters, that is the relative in French and millimeters. The cannulas are available from 6 French to 52 French size. The most important is the diameter of the cannula. All cannulas have been tested with water and not with the blood. So the viscosity and everything will keep on changing that. Usually we select a pressures or cannula, venous cannula with a drop of 20 mm of pressures and arterial cannula with a drop of 100 mm of pressures. I'll just skip these slides. What is important? The cannula is short plan because a big diameter cannula is always preferable. And these slides I already shown you. With different size of cannula, then what is the pressure drop, and depending upon the pressure drop, this is a 20 pressure drop, depending upon that, you can see like the number of cannulas. That much amount of flow it can give. So simplify that chart. This is the chart what I have shown you to you. With this, you have to seeing this chart, you have to decide which size of cannula you have to use. This is for venous also, same thing. And for VV ECMO, if you are using double limit cannula, this is a chart with which you can use the cannulas less than 2 kg or 2 kg, 12 French cannula you have to use. 5 to 10 kg, you have to use 15 to 18 French venous cannula. 10 to 20 kg, you can use 18 French venous cannula. And if you require, you have to use one more cannula for a return, then it becomes a VVV cannula. Okay. So this is for a Veno-Venous double limit cannula that you are using. Again, same with the weight and the chart. Another important factor is the size which matters. If you are using too big cannula which is just feeding the vessels, you have only a central hole from where it drains. It does not drain from the periphery. So it is always better to have a little lesser size of cannula than the actual size of the vessels. Then again, it depends on the design of the cannula, the wall thickness. The cannula should be included in the central space so that the blood does not enter the field if you are doing with the surgical techniques. Diameter has to be an appropriate size. Now, cannulation sites, you can cannulate aorta, the common carotid arteries, femoral arteries, arterial artery, axillary artery. In the venous side, you can cannulate insular jugular vein, you can use right atrium, superior vena cava, inferior vena cava, femoral vessels, superior vein, and left atrium. The site of cannulation basically depends whether you want to go for a central ECMO or trans-thoracic ECMO or a peripheral cannulation. Trans-thoracic or central ECMO usually you use when we are unable to wean off the patient from the bypass or heart-lung machines. That's the time you probably might use central cannulation, trans-thoracic cannulation. That will give a better drainage from right atrium, return will be the aortic root, so the flow will be much better. So when the patient is already on heart-lung machine or heart machine, you don't require to do anything for patient on that. Most of the times in ICC, what we are going to do is the peripheral ECMO. So you have to use lasers from either right atrial jugular vein, left atrial jugular vein, very rarely. Right carotid, right femoral, left femoral, right axillary artery or posterior for distal perfusion. Who should cannulate? That's a big question. This now again depends on your centers, whether it's a center, the unit has been held by the surgical staff or by the intensivists. Usually intensivists prefer to go Seldinger technique methods. Surgeon prefers that if it's open, that becomes the easier task for them. So that depends on that. Veno-Venous cannulation is less surgically demanding than the veno-arterial. You will be very careful for veno-arterial cannulation. And most of the staff with an appropriate training can be do cannulation. Complications are infrequent, but when they do occur, it can create a major problem. So it has to be, you have to have a surgical backup whenever you are doing any cannulations, because you don't know when the complication is going to be there, and if it's there, it's going to be a life threatening. So you will be very careful about it. Techniques may depend upon the mode of ECMO, which mode of ECMO you want to plan, age of the patients, and center specific. Technique can be Seldinger, semi-Seldinger, or open techniques. So in general, you prepare the patients, maintain the stability. If required, give some sedations, anticoagulations, suicide as we get in mind. I'll just quickly go through the next slides of semi-Seldinger techniques. So what we do is the semi-Seldinger procedures. The neonates available cannula, if you want to put Veno-Venous. Okay. These are the different sizes available. Okay. Vessel is prepared, then you divide down muscles, locate the vessels. In the incision you do it. Locate the vessels. This slide faster. Okay. Once you have located the vessels, you know how much you have to put it inside. Just measure the length which you want to put it. You put the skin incision above that. You don't put the skin incision on the step wound. Skin incision above the step wound side. So the puncture above that, put the wire, dilate it, and then insert the cannulas. And this is the most important position with the cannula being kept. Otherwise, suppose we are putting a double cannula, should be that the arterial part of the cannula should be facing upwards and forwards. That is most important to prevent the recirculation. If it is the other way around, the recirculation chances are more. This is double element cannulas to the blood flows. Venous pore is bigger than the arterial flow. Okay. And if you see, the venous part is going into IVC, connecting from the superior vena cava, and the flow is directly towards the RV. Seldinger techniques, we will be showing you those videos of Seldinger technique. Seldinger techniques you can do with a blind plunger, or you can use the help of imaging, like ultrasound guided, you can do it. That will help you to locate the vessels, sizing of the vessels, and confirm the position of the vessels. Fluoroscopy can also be used, but again, you don't get much of the liberties to stick the patient and use fluoroscopy most of the time. This is an important part how you maintain the tubular cannulas. This U shape has to be maintained to prevent it to get disclosure coming out. The Femoral Venous cannula, Seldinger technique, and how to fix it. This is the cannula position. And suppose you want to do a VA ECMO, because of recirculation, that 3 cannula is required. When you drain from superior vena cava, you drain from inferior vena cava, you return back to the RA. This returning will go to the RA, you return back to the RA, so that the chance of recirculation will be minimized. We know arterial open procedure. When I just go through, expose the vessels. This is neonates. Usually we cannulate interjugular and carotid. These are surgical steps which I'm not doing. Once open the carotid sheath, locate the vein and artery. Then check how much is what's the position, what mark you to fix, almost 2.5 to 3 centimeters in neonates. Do distal ligation when you are doing open technique. Then open the vessels and put the cannulas. Just speaking these slides. In the interest of time. This is the way you connect, so that there is probably blood loss and intestinal air going inside. You connect it. Distal cannula, there is again most important part. You have to consider whenever you are using an end artery. So whenever you are using femoral artery, you have to always consider distal perfusion. Otherwise, that limb will go in ischemia. So you have to always put a small return cannulas. Either you put it as a integrated femoral puncture, or you can put it as a you can take either a posterior tibial cut down and put the 6 French or 7 French cannula. That. Or you can put a bidirectional flow, so that will be easier to reconstruct. So you put the negative test with an open technique, and you put a graph here and center the vessel so that the flow can go in both directions. This is the cannula position. I think this we are going to discuss in the next after videos. So, ECMO cannulation surgical complications can be bleeding, infection, cannula malposition, tamponade, pneumothorax, and vascular injury in terms of perforation or dissection. And the cannulation complications have been reported in the registry, ELSO registry. Out of 394 reported patients, 62% had a cannulation related complications. So many a times you might come across some minor or major complications during cannulations. sometimes your cannula, whatever size cannula you are intending to put 29 French cannula, you may not able to put that. Try to go for a smaller size cannula. So then things can happen you to change the. So in the ELSO registry from 1985 to 2002, mechanical cannulation problems were there, and it has been seen in almost 11%, 10 to 11% in a neonatal and adult patient. Just cut short the talks. What is most important in cannula is selecting the size of cannula and the site of cannula. Whether you have to go for central or peripheral ECMO, that is what is most important. And then we'll have a now